Yes, my name is Ashoka Benedict Gomes, and I'm going to give a presentation on the guidelines in rheumatoid arthritis and osteoarthritis. A little bit about rheumatoid arthritis and the present recommendations for the drug use. Arthritis can affect the joints, bones, connective tissue, or skin. It's not just Arthritis is not just on the joints or the knees or the arm, the joints. It can also affect the skin, connective tissue, and bones. And depending on that, it can be classified as osteoarthritis, rheumatoid arthritis, psoriatic acid, or gout. The chances of getting arthritis increases with age, gender, genes, excess weight, injuries, infections, and work also can contribute. Osteoarthritis is the most common, and it's found in elderly patients. It's caused by wear of the joints and affects about 27 million people in the US, the most amount. Rheumatoid arthritis is more severe and more debilitating. It causes pain, swelling, and degradation of the joint cells. It is thought to be an autoimmune disease and is treated differently from osteoarthritis. It affects about 1.3 million people in the US, less than osteoarthritis, but a significant amount. The aim of rheumatoid arthritis treatment is to prevent further joint disease, control the patient's symptoms, and improve the quality of life and mobility. Rheumatoid arthritis treatment can involve both non-pharmacological interventions and pharmacological interventions like medications, which are disease-modifying anti-rheumatic drugs, DMARDs. They should be started as soon as the diagnosis of RA is made. Non-pharmacological interventions involve educating the patient about RA, providing adequate rest but not total inactivity, with some exercise, physical and occupational therapy. Nutrition and diet also should be looked at, and because RA patients are at risk for coronary disease and should avoid foods that increase cholesterol levels. Smoking and alcohol are also risk factors, so patients should be helped to quit smoking, and alcohol can cause liver problems and affect the choices of medication we can use. RA causes bone loss leading to osteoporosis, so efforts should be made to reduce bone loss by using calcium supplementation and using short dosing of steroids. Although there's a catch-22 on that, because low dose steroids, glucocorticosteroids, are beneficial in RA patients. Pharmacological interventions involve non-steroidal anti-inflammatory drugs and disease-modifying drugs, DMARDs. The treatment of RA per the EULAR 12 and the American Rheumatologic guidelines are represented in this graph here. The start of the treatment part 1 is based on the diagnosis of rheumatoid arthritis. If the patient can use methotrexate, then we will start methotrexate and use glucocorticoids for flares, RA flares, with a low dose glucocorticoids. Or sometimes a low dose glucocorticoid can be used for a long period of time. So when RA is diagnosed, treatment should be initiated with a DMARD. The first choice will be methotrexate, and then they would monitor the patient for 1 to 3 months with an expected change in 3 months, or to reach target in 6 months. If this does not happen, then the therapy should be adjusted. If the patient cannot tolerate the methotrexate targeted dose, 25 to 30 milligrams per week, or 20 milligrams per week for China, and 16 milligrams per week for Japan with folic acid supplementation. In patients with contraindications who cannot use methotrexate, then lefomide or sulfasalazine is used. 20 milligrams for lefomide, 3 grams per day for sulfasalazine. A short course of glucocorticoids could be started when starting or changing conventional DMARDs and should be tapered off quickly. If there's no improvement in part 1 treatment with methotrexate, then and there's no unfavorable factors present, then you could add a second DMARD. Change or add a second DMARD. At 3 months, again, they will evaluate and should be a target at 6 months. If not, then you can add a biological DMARD or a JAK inhibitor. If after methotrexate treatment and there was the presence of unfavorable factors like high disease activity or early joint damage or greater than 2 conventional DMARDs failure, then you would go straight to the biological DMARD. And again, you would evaluate for improvement at 3 months and target at 6 months. Both biological DMARDs and targeted DMARDs should be combined with the conventional DMARD for maximum efficacy. In patients that cannot use a conventional DMARD as a co-medication, IL-6 emitters and targeted DMARDs have advantages over biological DMARDs like TNF-alpha antibodies. If treatment with a biological DMARD or targeted DMARD fails, consider another biological DMARD or another TDMARD. If a TNF-alpha inhibitor fails, consider another TNF-alpha or another agent with a different mechanism of action like IL-6 or IL-1 or CD20. In persistent remission after glucocorticoids are stopped, one can consider tapering biological DMARDs. Similarly, persistent remission can start tapering conventional DMARDs. Some patients do not have a good response to TNF-alpha and require treatments with drugs having other mechanisms of action. These are the CD20 antigen antibody rituxan or Geljan's tofacitinib that target the Janus kinase pathway and IL-6 cytokine pathway. Geljan's or tofacitinib binds to JAK1 and JAK3 with greater affinity than JAK2 and tyrosine kinase, and all of these affect the transcription factors, STAT transcription factors, which affect other cytokine levels. In the selection of the DMARD, the guideline does not have a clinical preference for using a TNF-alpha inhibitor over a non-TNF-alpha or the choice of TNF-alpha inhibitor. It leaves the choice of the DMARD up to the physician and patient-specific factors. Usually a TNF-alpha inhibitor is tried first. However, present data from studies like the Monarch study has shown that IL-6 receptor antibodies were superior at reducing DAS28 ESR, DAS28 CRP, CDAI scores and improving the functional ability of patients intolerant to methotrexate compared to anti-TNF-alpha. There is increasing evidence that the positive results of the IL-6 receptor antibody blockade on DAS28 scores, and this represents a clinically effective role for IL-6 in rheumatoid arthritis patients. In studies, monotherapy with the IL-6 receptor antibody was shown to be superior to TNF-alpha antibody monotherapy, making anti-IL-6 receptor blockers a good selection in treatment of RA patients which had poor responses to methotrexate, with better efficacy than using a TNF-alpha. The American College of Rheumatology recommendations for osteoarthritis depends on the site of the osteoarthritis, hand, hip, or knee. Again, the non-pharmacological choices for hand osteoarthritis they recommend to figure out the ability to do the activities of daily living and guide the patient to use joint Protection techniques provide assistive disease devices, thermal devices, and splints. Pharmacological treatments for hand osteoarthritis include topical capsicum, NSAIDs, Voltaren gel, trolamine salicylate, or oral NSAIDs COX inhibitors, or tramadol. Not recommended intra-articular drugs, opioids. If age is greater than 75 years, then use topical instead of oral. Less than 75, they can use anything. This is for the hand. For the knee, the non-pharmacological choices are to do aerobic exercises, strong recommendations to do aerobic exercises, swimming, then lose weight. There are some recommendations to do manual therapy with directed exercising, do psychological interventions, use patellar taping, wear special wedge insoles, use thermal ducts, use walking aids, do tai chi, do Chinese acupuncture, use of transcutaneous electrical treatment. These have some recommendations. The guidelines suggest that it could have some benefit. There is no suggestions. They don't know if there's any benefit or any harm for balance or strengthening exercising, doing self-directed manual therapy and using knee braces. This is in knee. Then the pharmacological choices in knee osteoarthritis. There is some recommendations. They recommend some benefit for Tylenol, acetaminophen, oral and topical NSAIDs, tramadol, intra-articular corticosteroid injections. They say not to use quinidine and glucosamine supplements and topical capsicum. It's unclear if there's a benefit or no benefit for intra-articular hyaluronates, duoxetine, and opioids in knee osteoarthritis. In hip osteoarthritis, the non-pharmacological choices are strong recommendations: aerobic exercise, swimming, lose weight. Some benefit is to do manual therapy with directed exercising, do interventions, use thermal drugs, and use walking aids. There is no benefit or no harm found in doing balance strengthening exercises, doing self-directed manual therapy, and Tai Chi in hip osteoarthritis. The pharmacological choices for hip osteoarthritis, there's some recommendation for using Tylenol, acetaminophen, oral or topical NSAIDs, tramadol, intra-articular corticosteroid injections. Again, do not use quinidine or glucosamine. This is for hip. And there is no suggestions for intra-articular hyaluronates, duoxetine, topical NSAIDs, and opioids. And this is the course evaluation. Please click on this blue link to go to answer the couple of questions so we can evaluate this whole course. Thank you. And these are my references.